I'm also eager to listen to you, like all the other people who have joined today in this CME program. Please take over the mics.
Thank you so much, sir, and thank you for those very kind words. At the outset, I want to thank Tirumurugan for my very colleague, friend, and my classmate from JIPMA for inviting me for the IAP of Tamil Nadu State for organizing this very important session. My apologies, I am actually in a low network, so you may not be able to see me, but I'll ensure that the talk goes on well, and you'll all be able to see what I would like to address. So, Thiru, can you hear me?
Yeah, fine.
Okay.
Yeah,
Are my slides
and we can
visible?
see the slides also. Please go ahead.
Okay. Thank you so much. The objective of my talk would be to talk about why do we talk about CPAP? What is this CPAP? What are the indications? How do we titrate the knobs of CPAP? How do we monitor a baby on CPAP? When do we say that we have giving adequate respiratory support with CPAP? And when do we say we have failed on CPAP and we need to move up on the ladder for higher respiratory support? And what are the common troubleshoots and how do we address them? So these are, I'm not going to be very high end, as Thiru said that we have to talk about pediatricians who would like to manage babies on CPAP and avoid a lot of ventilator jargon. But at the same time, some basic principle will help us managing babies in the SNCUs and level 2 centers and prevent up transfers. So what is CPAP? Why do we talk about it? Because if you use CPAP judiciously, 80% of babies with respiratory support can be managed only with CPAP. So in any unit, if your requirement for CPAP is 80-20, that is 20% respiratory support with ventilation and 80% with CPAP, that means you are reasonably doing good. But if your ventilator requirement for babies with respiratory distress is more than 20%, that means you have a very good chance to improving the CPAP care in the unit. So CPAP, we all know, is continuous positive airway pressure. Why is it important? Because it improves something called functional residual capacity. That is the overall lung, which is available for gas exchange during the breath cycle. And we all know that FRC, or the gas exchange, is a crux of oxygenation. And most of the neonatal diseases, except for something like severe asphyxia where brain is not working, but rest of the all respiratory causes, the cause is FRC problem. So most neonatal problems are related to FRC, whether it is RDS, TTN, pneumonia, and many other respiratory distress. And that is why CPAP has turned to be the therapy or the respiratory therapy for babies with all the respiratory problems. And earlier in the disease course, we start CPAP, better are the outcomes. We all know that if you start CPAP for babies with respiratory distress in the delivery room, the subsequent need for mechanical ventilation and also BPD in extreme preterm babies can be dramatically reduced. So it is important to talk about this topic because it decreases ventilation. You can manage many babies, you can prevent up transfers, and you can give the best outcome the baby needs. So what do you mean by CPAP? CPAP means basically we are giving 4 things for the baby. One is a pressure. Second is a blended air and oxygen mixture. Third is a flow of gases, and these flow of gases are required to deliver pressures or generate pressures. And the fourth is vomidification or humidification of gases. The pressure we use in CPAP is from 4 to 8 centimeters of water. And this pressure we push into the nose, and this pressure goes into the alveoli and opens up the alveoli. So it keeps the alveoli open, thereby increases the FRC. So the pressure we use is from 4 to 8 centimeters of water. We do not use less than 4, and most people do not prefer to use more than 8, especially in babies, which all of us treat, that is from 28 weeks and above. Blended oxygen is giving FiO2 from 21 to 60%. We can give oxygen as low as 21%, that is air, or the maximum oxygen we would like to give on CPAP is up to 60%. And to generate the air oxygen mixture, we need a compressed air source, we need a compressed oxygen source and a blender. And that is when we can titrate the oxygen from 21 to 60%. And for generating pressure, we need flow of gases in the circuit. And the flow which is required for generating pressure of 4 to 8 is just 5 liters per minute. And all this gas which goes into the lungs should be warmed and humidified, because these are relatively high flow of gases. And the gases which are coming are from compressed air sources, which are cold and dry. We need to warm and humidify these gases when they're going into the nose. And that is the reason why all the gases which we use in CPAP, when they reach the nose, they should be at 37 degrees Celsius and fully moisturized with humidity. And for that, you need a good servo humidifier with a heated wire circuit. So basically, when we are giving CPAP for a baby, we're giving pressure, we're giving oxygen, and to deliver the pressures, we need flow of gases and warmth and humidification of gases. So as you can see in this figure, to generate CPAP or to give the CPAP, we need a pressure generator. In a bubble CPAP, it is this bottle where you immerse the expirator limb inside the bottle chamber or the bubble chamber, and the pressure is generated in this inside this chamber. And you need, for FiO2 to titrate between 21 to 60%, you need air, oxygen, and a blender, and that is required to titrate oxygen from 21 to 60%. For the warmidification, you need a good servo humidifier and with a heated wide circuit. So the gas is heated to about 40 degrees when it is coming out from the chamber and continues to get heated in the heater wire till it goes to the patient. At the patient end, it is about 37 degrees. When it goes to the nares, the temperature is maintained at 37 degrees with 100% relative humidity. So in infant flow drivers, the pressure generator, unlike the bubble generator, is the device. This device is at the nose, which is delivering the pressures. So when do we use CPAP? CPAP basically used for three categories of babies. One is for babies with respiratory distress. Second, babies or premature babies with recurrent apneas. And the third condition we use CPAP is post-extubation. If you're using a CPAP for a baby with respiratory distress, that is babies who have tachypnea, retractions, and or grunt, we use CPAP when in a preterm baby, less than 35 weeks, if the Silverman-Anderson score is more than 3. So remember that babies with respiratory distress, and if the gestation is less than 35 weeks and his SAS score is more than 3, that baby needs CPAP. That is, he's telling that his FRC is less. So you need to open the lungs, improve the FRC by using pressure, and that is CPAP. If it's a late preterm or a term baby, that is if the gestation is 35 weeks and above, and if the SAS score is more than 5, then we start CPAP for such babies. And in these sort of babies who have distress and CPAP is started, we start with CPAP of 5 centimeters, FiO2 of 30%, and flow of 5 liters per minute. But if you're starting CPAP for recurrent apneas, we start with a CPAP of 4 or 5 centimeters, FiO2 ranging from 21 to 30%, and flow of 5 liters per minute. For post-extubation, that is, if the baby is removed from ventilator and want to be supported on CPAP, we start with a CPAP of 5 centimeters, and you use the same FiO2 which you use to extubate the baby. Suppose a baby is extubated 25% FiO2, we start with 25%, and if the baby is extubated 30%, you start with 30% FiO2, but the flow rate is same. So across the board, the flow rate is same, and for most of the diseases where lung is a problem, we use the pressure of 5. If there is no serious lung problem like in apneas, you use a pressure of 4. FiO2 is based on if the lung disease is there, FiO2 of 30%. If there is no lung disease, you can vary from 21 to 25%. So as I said, the most important determinant for babies with respiratory distress is to know the Silverman-Anderson score. And this score can be easily calculated by looking at the upper chest, that is the upper chest above the mid-axillary line, lower chest, retractions below the mid-axillary line, xiphoid retractions, nasal flaring, and grunting. So you can add all these 5, you get a score of 0 to 10. And if the score is more than 3 in preterms, you start CPAP. And if the score is more than 5 in preterm babies, you start CPAP. In these videos, you can see that this baby has nasal flaring. This baby also has grunt. This baby has upper chest retractions, almost like a seesaw. And you can see that there are some lower chest retractions. There is also xephisternal retractions. So this baby's score was 7 out of 10. And this baby was 28 weeker, 1 kg. So this is a candidate who is saying that he needs CPAP. He needs to work on improving the FRC. So if you want to give CPAP, you can use any one of these devices. You can use a bubble CPAP, or you can use another CPAP, which is given by Zeal company, or you can use a ventilator CPAP. And to connect these machines to the baby, you need an interface. You can use a Hudson prong, you can use a Fisher and Paykel mask, or you can use a Ram's cannula. All of them are equally good, and the interface does not matter as far as the as long as the experience is improved. The more you are experienced using an interface, the better will be the respiratory outcomes and the nasal outcomes. So once you start CPAP, how do you increase the pressures? How do you titrate the FiO2 and flows? So for increasing or decreasing the pressure or CPAP pressure, you need to look at the retractions of the baby. So if the baby continues to have significant retractions, or if your SA score is same or worsening, and if the X-rays are showing low volume lung spaces, and if your saturations are less than 91%, you need to increase on pressure. So you can go from 5 to 6, 6 to 7, and very rarely you go more than 7. So increasing pressure is most of the time is based on presence of retractions or severity of retractions. The higher the retraction, the more might be the need for increasing the pressure. Now, once you increase the pressure, the retractions automatically decrease, or the SA score automatically decreases. And then once this is done, then you can titrate the FiO2 to maintain your saturation between 91 to 95%. So once your retractions are minimized, if saturations are still low, that means less than 91%, you can increase an FiO2 from 30 to 35, 35 to 40, and then you can go to a maximum of 60%. So, but always try to open the lungs first by increasing the pressure, and then if saturations are still low, you increase FiO2 starting from 30 to as high as 60%. You need not change the flow parameters much, because for generating pressure of 4 to 8, a flow of 5 liters per minute is quite sufficient. Very rarely you have to increase the flows, and before increasing the flows, you need always see that there is no leaks in the circuit. But how do you know that your flows are adequate? It will be known only by looking at the bubbles in the bubble chamber. In the bubble chamber in a CPAP machine, the flow should be continuous. That means both during the inspiratory and expiratory phase of the baby, bubbles should be seen in the bubble chamber. So the titration is basically if a baby is hypoxic and has retractions, then you keep increasing the pressure from 5 to 6, 6 to 7. However, if the baby is hypoxic, that is the saturation is less than 90%, but there are no minimal or no retractions, then you increase the FiO2 to improve the hypoxia. Now, when you decrease, if the baby's saturations are consistently above 94 or 95%, and if there are no minimal or no retractions, you decrease the FiO2. Suppose the baby is on 7 pressure and FiO2 of 50%, and if the retractions are minimal, but if the saturations are above 94, 95, you start decreasing the FiO2. So you can decrease the FiO2 from 50 to 45 and from 45 to 40%. For every 10% reduction in the FiO2, you can come down on the pressure. So from 7, you come down to 6. Now from 40% FiO2, you decrease the FiO2 to 35 and 30. And from 6, you come down on the pressure to 5 centimeters. Once he is on 30% and FiO2 pressure of 3 centimeters, you subsequently decrease the FiO2 to as low as 25% or 21%, and then only you decrease the pressure from 5 to 4. So that is how you will increase and decrease the pressure and FiO2 for a baby on CPAP. Now, while you are monitoring this, you are titrating the pressures and the FiO2s, you need to monitor the baby. The most important things which you need to monitor are heart rate, respiratory rate, capillary refill time. And if you're giving slightly higher pressures than what the baby requires, the chest could be hyperinflated and the CFT could decrease because of the decreased venous return. So increased CFT is a marker of chest hyperinflation or high pressure. So keep a watch on the CFT, and it could be one of the earliest marker that your pressure is high. Silverman score you need to continually monitor, because if it is increasing, that means your still FRC is low. You need to increase the pressure. And if Silverman score is gradually decreasing, that means your CPAP is working and you need to continue to use the same pressures. Breath sounds, you always need to auscultate on the axilla to hear for the breath sounds. If the breath sounds are heard in the axilla, that means your pressure is actually reaching the lung. Urine output needs to be monitored, because again, if pressure is high, venous return decreases and urine output could decrease. So the earliest marker of chest hyperinflation or excess pressure could be prolonged CFT and decreased urine output. Sometimes there could be an increased abdominal girth. So that is why whenever you start on CPAP, should always put a orogastric tube in place, and the tip of the tube should always be above the level of the tummy. And keep monitoring the CPAP pressure and FiO2. At the patient end, at the interface end, you need to maintain a distance between the cannula and the interface. So between the columella and the interface, there should be at least 2 mm distance. And then when you're using the CPAP prongs, the prongs should not dilate the nares. They should just snugly fit into the nose to deliver the pressure. There should not be any columella or septal damage, and there should not be any blanching on the columella or on the septae. And one needs to continuously ensure that there is nasal nares are constantly moisturized with saline or nasal drops, and always OG tube should be in place, and the tube should be open at least half an hour after feeding. In the machine end, you should always see for bubbles in the bubble chamber. Bubbles in the bubble chamber means pressure, whatever you have set, is maintained in the circuit. Bubbles heard in the chest means the pressure is reaching the lung, and bubbles in the bubble chamber means their pressure in the circuit is well maintained. Temperature should be 37 display on the humidifier, and the tubings, the circuit tubing should always be kept below the patient level. Flow rate should be always be maintained at 5 liters per minute. Very rarely, if the flow rate is requirement is increased, then that means there are some leaks and you should take care of the leaks. Never occlude the mouth of the baby to generate pressures or to decrease bubbles. We never use any passive. We can sometimes, very rarely, you need to use pacifier, but never use chin straps to occlude the mouth of the baby to generate pressures. How do we know that we are giving adequate CPAP? If the pressure is adequate, there will be minimal or no retractions. If the FiO2 is adequate, the saturations will be between 91–95%. And if the flow is adequate, there will be bubbles in the bubble chamber and bubble sounds will be heard in the chest. If the humidification is adequate, the temperature display on the humidifier will be 37 degrees and there will not be any condensation in the inspirator limb. And if you touch the inspirator limb, it will be warm to touch. And if you have a chest X-ray, the chest X-ray should show 6 to 8 spaces. If the chest X-ray is showing 6 to 8 spaces, FRC is adequate. That means your pressures are appropriate for that baby. Now, we have discussed to some extent how do we wean the baby from CPAP. So we take out of CPAP when the baby's pressure requirement is 4 and FiO2 requirement is 25% or less. If you're removing the baby from CPAP and if the baby is more than 1 kg, that is when the need for HFNC comes in. HFNC, high flow nasal cannula. And if the baby is less than 1 kg, we continue the baby on CPAP till the pressure requirement comes to 4 centimeters and FiO2 comes to 21%. And after removing the CPAP, if the baby has recurrent apneas, we continue to keep the baby on CPAP till another 24 to 48 hours. So sometimes you might have to keep the baby, extreme preterm babies on CPAP for weeks before you can take them out of CPAP, but they may be very comfortable on pressure of 4 and FiO2 of 21%. And if the baby is shifted to HFNC, that is babies more than 1 kg, if they are shifted to HFNC from CPAP, you start with 5 liters per minute and you maintain FiO2 of 21%. Maximum FiO2 you will deliver on HFNC is about 25 to 30%. And if the baby is maintaining saturations on FiO2 21%, you can continue to decrease the flows of HFNC from 5 to 4, 4 to 3, and then to 2. If the baby is able to maintain on a flow of 2 liters and FiO2 21%, you can switch over the baby to room air. Now, when do we say that your CPAP has not worked? You should label the baby having CPAP failure only when you optimize the delivery of CPAP. And after optimization, if the pressure requirement is more than 7 centimeters, and if the FiO2 requirement is more than 60%, that means he's not able to maintain saturations above 60%, even on FiO2 above 60%. And if he continues to have retractions on CPAP pressure of 7 or more, then you say the baby has failed CPAP. And then if the baby has failed CPAP, you can go on to nasal IMV or ventilation. Now, as I said before, you label the baby as failed or failed CPAP, you have to optimize CPAP. For that, you should ensure that there are no leaks in the circuit. How do you know that? The bubbles are seen in the bubble chamber. There are no leaks in the circuit. The bubble sound should be heard in the chest. Then only you can say that the pressure or the air is actually reaching the lungs. The humidification should be appropriate. That means there should not be any condensation in the inspirate limb, and the display temperature should be 37. The inspirate limb should be warm to touch. The nasal interface should be optimum, and it should be fitting snugly into the nose without causing excess dilatation and snubbing on the columella. The X-ray chest should show inflation of 6 to 8 spaces, and ideally there should not be any pneumothorax. And still, if you want to say that CPAP is optimized and it could be a cardiac problem, then you need to get an echo. And if PPHN is there, you can optimize PPHN by using supportive care before you can say if your CPAP has failed. Some of the troubleshoots which are very common in CPAP are, there could be baby is maintaining low saturations, he's having retractions. That means the pressure is inadequate or the pressure is not reaching the lung. How do we know which of these is possible? So if the air entry is poor, but bubble sounds are heard in the or seen in the bubble chamber, that means the pressure is built in the tube, but it's not reaching the lung. This could occur if there is a nose block, or the nose block is not there, but the lung is severe and FRC is very low, or there could be a worsening of lung disease. So you need to increase the pressure, keep increasing the pressure to pressure of 7 before you can say that your things have not worked. Very rarely, if the lung disease, very often, if the lung disease is showing RDS picture on the X-ray, along with CPAP, you can add on surfactant. And if the FiO2 requirement is more than 30%, if the retractions are persisting, hypoxia is there, you can add on surfactant early to prevent the increased need for pressure. If the baby is hypoxic, there are no retractions, air entry is good. That means the pressure is reaching the lung and bubbling is there. But baby is hypoxic. That means the lung volume is all right. FRC is all right. But oxygenation is not good. When do you get that problem? That problem means there is a problem beyond the lung, which could be a PPHN or a heart disease, or your blender is malfunctioning. You have set 30%, but the blender is giving only 21%. So these are the reasons for hypoxia when there are no retractions and bubble sounds are seen and heard. If there is hypoxia, retractions are there, air entry is good and bubbles are not seen in the bubble chamber, definitely there is a leak in the circuit or mouth leak. If there is condensation in the inspirate limb, this means your heater wire is not working or your room temperature is low, very low. Most of the CPAPs are destined to work best if the room temperature is between 26 to 28. Or the distal part of the circuit is not under warmer. Especially the last part, if it's not under warmer, there could be a dramatic drop in the temperature before it reaches the nares, and that could lead to condensation in the inspirator limb. You should expect some amount of dew drops or droplets in the expirate limb. If there is no droplets or dew drops are not seen in the expirate limb, that means your humidifier chamber is not working or there is no water in the humidifier chamber. What all we can do to improve the efficacy of CPAP or all the non-invasive modes of ventilation? For that, we need to improve the interface, whether it is mask or RAM or Hudson prongs. We need to work on one of them and keep working on them to improve the efficacy. Always, I prefer to use the bubble CPAP machine. I find it the best to monitor and also to deliver CPAP. And it's the most cost-effective machine. For a titration of FiO2, you need air, oxygen, and blender. And you need a good servo humidifier to deliver proper humidification. I would rate humidification is the 50% of CPAP. So 50% of CPAP is correct humidification. Another 50% is blended oxygen and pressure. So always ensure appropriate humidification. The gas should reach the nose at 37 with no condensation in the inspirate limb. Monitor the baby, monitor the interface and the machine to get to early troubleshoot and work on the interface or machine or the baby. Simplify the setting. Always think of pressure of 5, flow of 5 liters for most of the settings. If the pressure requirement is increasing, you can work on increasing for working on surfactant or other mechanisms rather than keep increasing the pressures. So if you're working in a level 2, you can just imagine that if you put the baby on CPAP of 5, FiO2 30% and flow of 5, most of these babies, at least 70 to 80% of babies are comfortable. But if the baby continues to have retraction, add on surfactant, and you can do LISA or MISA with the CPAP, and many more babies will come out of CPAP. Very rarely you will fail CPAP if you use pressure of 5, FiO2 30% and flow of 5, and add on surfactant early. Always know the troubleshoot where you have to work on, whether it's FiO2 or pressure, or if there is a problem, how do you address those problems? And early use of adjuvants like surfactant or caffeine have dramatically improved the outcomes of babies on CPAP. And the other thing is delivery room CPAP. Start with CPAP in the delivery room with the TPs and continue with the bubble CPAP in the NICU to get the best outcomes. If you're using too much of CPAP, definitely there is a need for backup ventilation, because I said that 15 to 20% of babies could fail CPAP, and those babies you need to work upon ventilation or have a nearby facility where you can refer if the CPAP fails. So just to summarize, CPAP is a primary respiratory support for babies with respiratory distress. Whether it is respiratory distress or recurrent apnea or post-extubation, CPAP is the gold standard now. HFNC is as its role, but I feel it is used mostly for post-CPAP. Instead of using plain nasal oxygen, you can use warm humidified oxygen with HFNC, and mostly for babies more than 1 kg. HFNC as a primary mode of respiratory support, I feel has the failure rates are very high. So I would advise using after CPAP, especially for babies who have significant FRC problems. Nasal IMV, some countries use it as a primary mode, but it is not the cost-effective way. And the training and the usage of nasal IMV is definitely much higher compared to training of the nurses for CPAP. So if you still want to learn further, please go to a preterm care package. This is available on www.pretermcareeliminatingrop.com, and you can enroll here free of cost, and you can go through the module of CPAP to learn complete basic package of CPAP. Or you can look at my YouTube videos. How do we set a machine? How do we titrate the CPAP? And other YouTube videos are available. Or you can buy a CPAP module, or you attend one of the CPAP workshop, which is commonly conducted across the country. And or you can do observership in units like JIPMER or with Tirumurugan and other people who are doing CPAP in the country. So thank you everyone for giving me this opportunity.
Thank you very much, sir. It was so, you made CPAP so simple and so lucid.